Welcome back to this next video in which we are discussing coronary artery disease. Okay, so we're currently in the process of discussing the drug treatment for angina, and we've split up the drug treatment for angina into 3 different categories of drugs. The drugs that are going to be given to people with angina to have an anti-atherosclerotic effect, i.e. statins, to try and prevent the atherosclerotic disease getting worse. The drugs which are going to have an anti-anginal effect, i.e. they are given to try and prevent the angina, the chest pain upon exertion. And finally, a category of drugs that we haven't come on to yet, which is the drugs that are going to try and prevent acute coronary syndrome, i.e. which are going to try and prevent thrombosis if the atherosclerotic plaque does rupture. Okay, so we're currently on the anti-anginal drugs, and we just talked about the nitrovasodilators, which are often given to people who are suffering from angina. What I now want to talk about is the beta blockers. So the next category of drugs is the beta blockers, and specifically we're going to give beta-1 selective beta blockers. Okay, so I'll give you some examples. So these are going to be beta-1 selective beta blockers. So some examples of beta-1 selective beta blockers that are regularly used, and I mean obviously if you go onto Wikipedia and type in beta blockers, you'll be able to bring up a huge, great long list of different drugs that are beta blockers, but I'm just going to give you some examples that are commonly used. So examples of beta-1 beta blockers are atenolol, metoprolol, bisoprolol. They are the main 3 that I know the names of off by heart. So atenolol, metoprolol, and bisoprolol. Okay, so these are all beta-1 selective beta blockers, and you would want to ideally give a beta-1 selective beta blocker in the case of angina rather than a non-selective beta blocker, because you don't want to block beta-2 receptors, because remember, the beta-2 receptors are on the vascular smooth muscle cells of the coronary arteries, and during exercise the sympathetic stimulation to the heart and also to the coronary arteries goes up, and sympathetic stimulation onto the beta-2 receptors on the vascular smooth muscle cells is actually responsible for their relaxation and therefore the vasodilatation of the coronary arteries. So you would not want to block that effect. That's going to make the angina worse. What you do want to block is the stimulation on the heart, which is done through beta-1 receptors, which is why we're going to use a beta-1 selective beta blocker. So let me just firstly draw a picture of a beta-1 receptor. So it is a classical G protein coupled receptor with the 7 membrane spanning alpha helices. So here is a picture of one sitting in the phospholipid bilayer of the cell membrane, like so. Okay, so this will be on cardiomyocytes all over the heart, these receptors, and when you exert yourself, we've talked about how sympathetic stimulation goes up to the heart, and this is going to be acting, well, this noradrenaline that the cardiac nerves release onto the heart is going to be acting on beta-1 receptors on the cardiomyocytes. And in the sinoatrial node, this causes an increase in heart rate, so it causes an increase in the rate at which the sinoatrial node cells fire off electrical signals. And on all the other cardiomyocytes of the heart, it causes increased inotropy, increased force of contraction. So whenever the cardiomyocyte does contract, receiving an electrical signal to contract and then does contract, it's going to be doing so with more force. Okay, so it's going to be consuming more ATP. Right, and it's this increase in sympathetic stimulation onto the heart that is actually going to cause the problem, because that's going to increase the amount of work that the heart muscle cells are doing, and therefore it's going to increase the oxygen demand, and that oxygen demand isn't going to be met by the vasodilatation of the coronary arteries in the case of this stenosed coronary artery with the atherosclerotic plaque in. So the cardiomyocytes downstream of that are going to become ischemic. Okay, so if we could reduce the sympathetic stimulation then onto the cardiomyocytes, then we could reduce how hard they're having to work during the exercise, and therefore we could reduce the level of ischemia and reduce the lactic acidosis and reduce therefore the angina. And that's exactly the principle of what beta-1 selective beta blockers are going to do. They're going to bind to and block these beta-1 receptors. And remember, these are just competitive antagonists, so they bind to the receptor, they don't stimulate the receptor, so they bind, they block the binding site for noradrenaline, so noradrenaline can't bind to the receptor anymore, but they themselves do not stimulate the receptor in the way that noradrenaline would. So they just bind and then have absolutely no effect on the receptor, but what they do is block the binding site so the noradrenaline can't bind. That's just the basic concept of what a competitive antagonist is, so I'll write that key term here. Okay, right, and thereby they are going to block the sympathetic stimulation on the heart. Now, usually at rest there is very little sympathetic stimulation on the heart. Sympathetic tone on the heart is very, very small, so although the sympathetic tone will be compromised by giving these drugs on a regular basis, sympathetic tone on the heart is so small that that's not really going to have much of an effect. But it will slow the heart down a little bit and reduce the force of contraction a little bit because you will have reduced the sympathetic tone. But the main idea here is that we're going to reduce the sympathetic stimulation on the heart during the exertion period and therefore reduce the amount of work that the heart's going to have to do during that exertion period. Okay, so as I say, sympathetic tone on the heart is very small, parasympathetic tone is much higher, so the reduction in sympathetic tone isn't the major reason that we're giving these. It's to reduce the amount of stimulation that the cardiomyocytes are receiving when you go into a period of exertion. Okay, so the beta blockers are one of the first-line treatments then for angina. So most people who are suffering from stable angina will be put on a beta blocker. They will probably also be given glycerol trinitrate to use as required, and they'll also be put on a statin and also the category 3 therapy that we're about to talk about, where you want to prevent thrombosis from occurring over a ruptured atherosclerotic plaque. There is one more type of drug that I want to discuss under the anti-anginal heading, however, before we go on to the drugs that are intended to prevent thrombosis in the case of a ruptured atherosclerotic plaque, and that category of drugs is the calcium channel blockers. Okay, right, so you can also prescribe calcium channel blockers. These aren't the first line treatment for angina, they're more a sort of second line treatment that you would give if the beta blocker with the nitrovasodilator wasn't enough to actually relieve the symptoms of angina. Okay, so calcium channel blockers. Okay, and CCBs, of course, is the abbreviation for calcium channel blockers, so I'll just write it out in full. So the first C is for calcium, the second C is for channel, and then the B is then for blockers. Okay, right. Now, you will know that there are 3 different categories of calcium channel blockers: the dihydropyridines, the phenylalkylamines, and the benzothiazepines. And they all work by blocking L-type voltage-gated calcium channels, so I'll just write these 3 categories down. So there are the DHPs, which stands for dihydro, that's the DH, and then the P is for pyridine. Okay, or pyridines. And by the way, these categorizations of the calcium channel blockers into these 3 different categories, they are chemically based. Okay, so they all do the same thing. Biologically, they're all grouped under this heading of calcium channel blockers, and they block, as I say, L-type voltage-gated calcium channels. The subdivisions into these further 3 categories, this is based on their chemical structure of the drugs. Okay, so all the dihydropyridine calcium channel blockers have a certain chemical structure that they're based on, the dihydropyridine structure. Okay, the same for this next category, which is the phenylalkylamines. Okay, so the second category is the phenylalkylamines. And then the third category is the benzothiazepines, which you should be careful not to confuse with benzodiazepines, very different drugs. Okay, so benzothiazepines. Right, now the dihydropyridines are the ones that are of interest to us here, because the phenylalkylamines and the benzothiazepines, they have more of an effect on L-type voltage-gated calcium channels in the heart. So L-type voltage-gated calcium channels is going to be the target for calcium channel blockers. They're all going to block the pore of L-type voltage-gated calcium channels, which I'll abbreviate down to VGCCs. Okay, and that's their therapeutic target. However, these different categories here target, they have different abilities for targeting L-type voltage-gated calcium channels in different tissue. Phenylalkylamines, the archetypal example of which is verapamil, are very good at blocking L-type voltage-gated calcium channels in the heart. That's not what we're going to be doing in the case of angina. Okay, we don't want to block the L-type voltage-gated calcium channels in the heart in the case of angina. So verapamil isn't generally used to treat angina. The benzodiazepines, they're somewhere in the middle between blocking L-type voltage-gated calcium channels in the heart and L-type voltage-gated calcium channels in the vascular smooth muscle cells. And the major example there is the drug diltiazem. Okay, again, diltiazem isn't generally used in angina. It's the dihydropyridines that we're going to be that is going to be of interest to us in treating angina. These are the drugs that are very, very good at blocking L-type voltage-gated calcium channels in vascular smooth muscle cells. And by blocking L-type voltage-gated calcium channels in vascular smooth muscle cells, you can stop calcium coming into the cytoplasm of the vascular smooth muscle cell, and hence stop signals to contract in those vascular smooth muscle cells. And this effect going on all over the body is going to cause a very similar effect to the nitrovasodilators. So firstly, before I draw a picture of this mechanism, let's just give some examples then of dihydropyridines. So there are absolutely loads, again, like there are loads of beta blockers, but some major examples to know are nifedipine, that's the real prototypical one. Nicardipine is also a very famous one, and amlodipine is a very famous one. So these are three notable examples of dihydropyridine L-type voltage-gated calcium channel blockers. Okay, right. So you can take these drugs then, and you take them regularly, and they will go into your circulation, and they will block L-type voltage-gated calcium channels in vascular smooth muscle cells. So if I give a little picture here, let's say this is my vascular smooth muscle cell, so I'll call this a VSMC for short, just for vascular smooth muscle cell, and I'll colour it in here in red. Okay, so how do vascular smooth muscle cells then receive the instruction to contract? Well, we know that at the utter centre of the control of the contraction of vascular smooth muscle cells, there is the enzyme myosin light chain kinase. We've seen this earlier. Okay, so myosin light chain kinase, its on or off state controls how contracted, or the state of contraction of the vascular smooth muscle cell. Okay, now that means that things that activate myosin light chain kinase enzymes are going to increase the contraction of the vascular smooth muscle cell, and things which inactivate myosin light chain kinase enzymes are going to decrease the contracted state of the vascular smooth muscle cell. They're going to produce relaxation. And we saw the example of protein kinase G earlier. We also mentioned the example of protein kinase A, which was activated by beta-2 adrenoreceptors. Now what I'm going to give you is an example that can actually activate myosin light chain kinase enzymes. And the molecules, the main example of a molecule that can activate myosin light chain kinase enzymes are complexes of calcium with calmodulin. Okay, so calcium-calmodulin complexes. So calmodulin, often abbreviated down to CAM in this way with capital C, lowercase a, capital M. Okay, this is a protein inside of smooth muscle cells that is normally inactive. So when it hasn't got calcium bound to it, it's inactive and is not going to bind and activate myosin light chain kinase enzymes. However, when it binds calcium ions, it changes conformation and can then go on and activate myosin light chain kinase. In particular, it binds 4 calcium ions. So I'll just actually draw a little picture of this. So in the inactive state, it kind of looks like this, and this is a real representation of what it looks like. It has these 2 lobes. One's called the N lobe because it's at the amino end of the protein. One's called the C lobe because it's at the carboxylic acid terminus of the protein. Okay, and each of these lobes has a binding site for calcium, which I'll show here in blue. So these are the calcium binding sites. And then it has a linker between the 2 lobes. And this linker, when it's in the inactivated state, it's sort of, it's curved around like this. The lobes are bent back towards one another, and it really does almost have a hunch like this. Okay, so this is the inactive form of calmodulin, sometimes called apocalmodulin. So this is sometimes written APO, the form of calmodulin before it's actually activated, and then I'll just put the abbreviation for calmodulin, CAM, here. Okay, so you have lots of these proteins in the cytoplasm of a vascular smooth muscle cell, and then if calcium goes up in the cytoplasm of the cell, because of course I'm sure you're aware that calcium is usually kept at a ridiculously low level inside the cytoplasm of all cells. It's usually at something like 100 nanomolar, which is tiny. Okay, so inside the cell the calcium concentration is around 100 nanomolar. Contrast that to the extracellular calcium concentration, which is usually around 1.5 millimolar, so there's a 15,000-fold gradient of calcium across the cell membrane. When calcium goes up inside the cytoplasm, it will bind to the calcium binding sites of calmodulin molecules, and when the calmodulin molecule gets 4 calciums bound to it, 2 to each lobe, it changes conformation and then starts to look like this instead. Okay, the linker takes an alpha helical structure rather than a linear structure as it had before, and now it's sort of, instead of being hunched over in that way, it's gone linear effectively. So these in orange here, these can represent the calcium ions now bound to those calcium binding sites. So this is now a picture of the calcium calmodulin complex then here. Okay, and these calcium calmodulin complexes, they can then go on, bind to all sorts of other proteins and change their function. And it's one of the major ways then that calcium signals in the cytoplasm can actually affect the behavior of proteins through calmodulin proteins. So the calcium binds to the calmodulin protein, changes the conformation of the calmodulin protein, and then the calmodulin protein can bind to a huge number of different proteins and change their behavior. It means that calcium signals can affect the behavior of lots of proteins without all of those proteins that they're going to affect actually needing to have a calcium binding site themselves. Instead, the calcium binding site is through this accessory protein, calmodulin. Okay, so when calcium goes up then in the cytoplasm of the cell, you get calcium calmodulin complexes forming. These bind to the myosin light chain kinase enzymes and activate them. Okay, so calcium is one of the major things then that promotes the contraction of vascular smooth muscle cells. And where do they get calcium coming from in their cytoplasm then? Well, there are 2 major places that vascular smooth muscle cells can get calcium coming into the cytoplasm, either from the intracellular stores, so principally the endoplasmic reticulum. I'm not sure whether if in a vascular smooth muscle cell you refer to the endoplasmic reticulum instead as the sarcoplasmic reticulum. You certainly do in cardiomyocytes and skeletal muscle cells, but I'm not sure whether you do in vascular smooth muscle cells. Anyway, the endoplasmic reticulum or the sarcoplasmic reticulum, whatever it's called in vascular smooth muscle cells, it's the major store of calcium, and calcium can of course be released from the inside of the sarco or endoplasmic reticulum, and that can then activate calmodulin proteins. Alternatively, it can come from the extracellular fluid, and this is actually the more common way that you get calcium coming into vascular smooth muscle cell cytoplasm rather than released from the intracellular store. And one of the main ways that you can get calcium coming in is through the activation of L-type voltage-gated calcium channels. So let's say this is an L-type voltage-gated calcium channel. So vascular smooth muscle cells will have a huge number of L-type voltage-gated calcium channels in their cell membrane, and these will be opening all the time in response to little depolarizations in the electrical potential difference across the cell membrane of the vascular smooth muscle cell, and they'll be allowing calcium into the cytoplasm of the cell, and this will be signaling for contraction of the vascular smooth muscle cell. When we expose the entire circulatory system then to these dihydropyridine drugs, nifedipine, nicardipine, amlodipine, they're going to block these L-type voltage-gated calcium channels, and you're going to get much less calcium signaling occurring in the vascular smooth muscle cells. Hence, the contracted state of the vascular smooth muscle cells all over the body is going to reduce. You're going to get vasodilatation of blood vessels all over the body, both the veins and arterial blood vessels. Okay, and that therefore is going to have the same effect as the nitrovasodilators. So again, this has a prophylactic effect. It's going to reduce the amount of work that the cardiomyocytes are actually having to do to pump blood from the venous system to the arterial system, and that's going to make the heart more able to cope with exertion. Okay, because it's not going to use as much energy when it is actually exerting itself, because of the fact that arterial and venous blood pressure are both reduced. Okay, so that's the calcium channel blockers, and as I say, this is second line treatment. So the first line treatment would be a beta blocker with a nitrovasodilator, glycerol trinitrate usually, to take as required, potentially with with isosorbide mononitrate to take prophylactically. Okay. Calcium channel blockers would then only be used if that was failing to deal with the symptoms of angina. Okay, now what I want to move on to then is the third category of drug treatment to give to people who are suffering with angina, and this is the drug treatment that we give to try and prevent thrombosis from occurring over ruptured atherosclerotic plaques, to try and prevent the person suffering from the acute coronary syndrome. So these are now going to be anticoagulant medications. Coagulant. Right, okay, so I will just remind you of the process of thrombosis over the ruptured surface of an atherosclerotic plaque, because understanding that's going to be extremely important to understanding the mechanisms of these drugs. So if I just find my picture, just bear with me a moment. Okay, here we go. Right, so remember when we started talking about acute coronary syndromes, I gave you a discussion of what actually happens in the formation of a thrombus. So you get the rupturing of the surface of the atherosclerotic plaque, and we know that what that does is it exposes the things in the blood, so platelets and coagulation factors principally, to molecules that they would have never been allowed to see before, and one of the major examples is collagen. Okay, so there are two parts to the formation of the blood clot, or the thrombus, or indeed the hemostatic plug if it was occurring in a more physiological scenario, such as a hole inside the blood vessel, which are the formation of a platelet aggregate and the formation of a fibrin mesh. So to form a platelet aggregate, there are these three steps here. Firstly, you get platelet adhesion, so certain platelets, the first to be on the scene, will actually adhere to the ruptured surface of the atherosclerotic plaque, and they are binding to these molecules that they would have never previously been allowed to see, which they've got receptors to. Okay, those platelets are then going to activate, and activation involves changes in their properties, and one of the major changes is that they can now aggregate, they can bind to other platelets that have also been activated, but they can only bind to other platelets that have also been activated. Now remember, if you're trying to make a hemostatic plug, you don't just want platelets to adhere around the exposed surface of the blood vessel wall. You want the platelets that are in the middle of the hole, okay, to also start binding together so that you form a plug through the entire hole. So you want to get more platelets sticking on top of the platelets that have adhered to the broken wall surface. Okay, so you somehow need to get the platelets that are in the middle of the hole to activate as well. So another key part of activation is the chain reaction, and in order to produce this chain reaction, the activated platelets release ADP and thromboxane A2, and these molecules go off and bind to receptors on other platelets and cause them to activate as well. So they change their properties so they can bind to other platelets and also release these molecules to continue the chain reaction. Then what can happen is these platelets that haven't actually adhered to the broken surface of the blood vessel wall or to the ruptured surface of the atherosclerotic plaque can then adhere on top of the ones that have. Okay, they can aggregate on top of the ones that have, and that's the third step, platelet aggregation. Are the major anticoagulants that are given to try and prevent thrombosis in people with ruptured atherosclerotic plaques? Well, of course, the major anticoagulants that are given to people with stable angina to try and prevent thrombosis from occurring if their atherosclerotic plaque was to rupture, that's the better way of saying it, target these. They're going to target ADP and target thromboxane A2, and they're going to try and prevent this chain reaction. Okay, so I'll come back to their mechanisms in just a moment. Remember, the other part of the coagulation process are the coagulation cascades, which activate the production of a fibrin mesh. So usually you've got fibrinogen, coagulation factor 1, circulating within the blood in this inactivated state. the coagulation cascades becoming activated, and of course these are an utter nightmare to learn, there's loads of coagulation factors involved in these, but overall understand that these coagulation cascades are going to be activated by being exposed to molecules that they would have never been allowed to see, such as collagen. They're also going to be activated by the membranes of activated platelets. So platelets which have undergone activation, they change the constituents of their cell membranes so that the coagulation cascades that can now be activated by the coagulation factors on the surface of those activated platelets. Okay, and this is going to result overall in the conversion of fibrinogen into fibrin, which is factor 1A. Factor 1A polymerizes spontaneously, and then it gets cross-linked. These fibrin polymers you produce get cross-linked together by factor 13A, which is activated from factor 13 by the coagulation cascades. And this fibrin mesh production around the platelet aggregate is extremely important to give the blood clot structural soundness, okay, to make it actually solid. The platelet interlinks are very, very weak and would just sort of break apart without the fibrin mesh. Okay, right. So the important thing to understand is that if we stop the chain reaction of platelet activation, then we're only going to get some platelets adhering onto the surface of the ruptured atherosclerotic plaque. Okay, those ones will be activated, but none of the other platelets will be activating. And remember, the surface of activated platelets is one of the major things to start the coagulation cascades off. So if we get very few platelets actually activated, then we're going to get very little of the coagulation cascades activated. So the major way then that we can block coagulation from occurring is by blocking the chain reaction. And to block the chain reaction, what we need to do is block these molecules here. Okay, so there are two agents then, or two categories of agents which can block this chain reaction, and they together are known as the antiplatelet anticoagulants. So they are going to be anticoagulant drugs, but they're also known as the antiplatelet drugs because they stop platelet activation, and that's the means by which they actually achieve an anticoagulant effect. Okay, so the first one I want to mention is of course the drug aspirin. Most people who are deemed to be at risk of having a heart attack are on long-term aspirin where they take it every day. Okay, so let me just explain how aspirin is going to work. Aspirin works by blocking platelets from being able to synthesize thromboxane A2. Okay, so remember, one of these molecules, these chain reaction molecules that platelets can release in order to activate other platelets, is thromboxane A2. This one is actually synthesized directly once the platelets have actually been activated. So once the platelet has been activated, it starts making loads of thromboxane A2. Aspirin is going to work by going into the activated platelets, well, will already be in the activated platelets before they've actually activated, okay, and it will inhibit the enzymes that are needed to make the thromboxane A2, and therefore, even though the platelet is activated, it won't now make thromboxane A2, or at least will make much less thromboxane A2, and therefore we're going to help limit this chain reaction. Okay, so let's just remind ourselves of the cyclooxygenase pathway then, because it's so important. So in order to make thromboxane A2, what you need to do is convert arachidonic acid into prostaglandin H2. Okay, so all of the eicosanoids, of which thromboxane A2 is an example, start off from being synthesized by a fatty acid, which is arachidonic acid, a 20-carbon carboxylic acid. So arachidonic acid is the starting point for the synthesis of thromboxane A2. To make thromboxane A2 then from arachidonic acid, the first reaction that has to happen is the conversion of arachidonic acid into prostaglandin H2. And this goes via another molecule, an intermediate molecule, which is prostaglandin G2. So first the arachidonic acid is converted into prostaglandin G2, then it's converted into prostaglandin H2, and then from prostaglandin H2 you can go to thromboxane A2. Okay, so PG is for prostaglandin, and then the G2 is just for G2, and the H2 is just for H2. So PG stands for prostaglandin here. So, to make thromboxane A2 then in these activated platelets, you have to take arachidonic acid, convert it into prostaglandin G2, then into prostaglandin H2, and then you can turn it into thromboxane A2. Now, aspirin is going to inhibit this process by inhibiting the enzyme which catalyzes both of these conversions here, the conversion of arachidonic acid into prostaglandin G2 and the conversion of prostaglandin G2 into prostaglandin H2. And the enzyme, or the class of enzymes which catalyze this, are known as the cyclooxygenase enzymes. Okay? Specifically, in the case of platelets, cyclooxygenase 1 is extremely important. So there are different types of cyclooxygenase enzymes. The main two are cyclooxygenase 1 and cyclooxygenase 2, and for short they're often abbreviated down to COX enzymes, C for cyclo, ox for oxygenase. Okay, so cyclooxygenase enzymes then catalyze the conversion of arachidonic acid into prostaglandin G2. That's known as the cyclase reaction, or the cyclooxygenase reaction. And then they catalyze the conversion of prostaglandin G2 into prostaglandin H2, which is known as the peroxidase reaction. So both of these reactions are so important, they have names. So this one's known as the cyclooxygenase reaction because it creates a cycle in the molecule. Okay, so if you actually look at the structures of these molecules, you'll understand why it's called the cyclooxygenase reaction, because you create a little cycle in the molecule. And then this one is the peroxidase reaction because you break a peroxide link in the molecule. So this is the peroxidase reaction. So just a little bit of bonus information there. Right, so to summarise then, aspirin is going to work by inhibiting the cyclooxygenase enzymes. Aspirin actually inhibits both cyclooxygenase 1 and cyclooxygenase 2. The one that's particularly relevant to platelets is cyclooxygenase 1. So aspirin will go into platelets, inhibit cyclooxygenase 1, and this will mean that when the platelets do get activated, if they get activated, then they're no longer going to actually be able to produce thromboxane A2, because to produce thromboxane A2 you have to have this enzyme functional. You have to be able to convert arachidonic acid into prostaglandin G2, then into prostaglandin H2, and then into thromboxane A2. And in order to convert arachidonic acid into PGG2 and then into PGH2, the so-called cyclooxygenase and peroxidase reactions, you need functional cyclooxygenase enzymes, and they're not going to be functional once exposed to aspirin. Hence, the platelets are not going to be able to release thromboxane A2, so you hugely reduce that chain reaction. And if you don't get enough platelets undergoing the chain reaction, you're not going to get a platelet aggregate forming, and you're also not going to get the coagulation cascades activated properly, so you're not going to get a fibrin mesh, hence the antithrombotic effect. Okay, so aspirin is a key example of an antiplatelet. Then, the other category of antiplatelets, anticoagulants, are what are known as the P2Y12 antagonists. And there are multiple different examples then of P2Y12 antagonists. So these both have very different mechanisms, but they're both referred to as antiplatelet anticoagulants because they're going to block the chain reaction of platelet activation. Okay, so examples then of P2Y12 antagonists. The most important example, the old example, is clopidogrel. But there are other examples now. Another example is prasugrel, more newer drugs. And then there's another example which is ticagrelor. So clopidogrel, prasugrel, ticagrelor, they're all examples of P2Y12 antagonists. Okay, now aspirin blocked thromboxane A2, P2Y12 antagonists are going to block ADP. Now, unlike thromboxane A2, ADP is not synthesized on the spot when the platelets get activated. Instead, ADP is stored in granules inside the platelets known as dense granules. So if I just draw a little picture here. So if this is our platelet, then the platelet has inside its cytoplasm granules known as dense granules. And one of the things in these dense granules, there are a huge number of different things in these dense granules, is the ADP. And platelets will release these dense granules, they will exocytose these dense granules when they are activated, and therefore this is the means by which they release the ADP. So release of ADP is very different from the release of thromboxane A2. This is made on the spot once the platelet has been activated, whereas this is stored for a long time pre-activation and then released once the platelet has been activated. However, this means that we can't block this being synthesized in the way that aspirin blocked the synthesis of thromboxane A2. So instead, the way that we block ADP from actually activating other platelets is to block the receptor for ADP. So if this is another platelet here, the one that is potentially going to be activated by the ADP that's been released by this one, we're going to block the receptor for ADP that is on this platelet. And the receptor is a G protein coupled receptor by the beautiful name of P2Y12. Okay, so whenever you see P, it means that it's a purinergic receptor. It's going to be activated by purines, or molecules that are based on purines, which of course ADP is. It's got an adenine molecule as part of its structure, the organic base adenine, which is a purine. Okay, so P2Y12 is a specific receptor that is very good at binding to ADP. Okay, so ADP molecules that have been released by this platelet that's been activated can go and bind to this receptor, and that will activate signaling pathways inside this platelet that will lead to it being activated as well. The P2Y12 antagonists, clopidogrel, prasugrel, ticagrelor, they're just going to be competitive antagonists for this receptor. They will bind to the P2Y12 receptors on the surface of platelets, and they will not activate the P2Y12 receptors, but they will block ADP from being able to bind there, and therefore, if the ADP is released, it won't have any effect. They basically make the platelets deaf to the actual ligand for this receptor. Okay, right, so that's the means by which P2Y12 antagonist antiplatelet anticoagulants are going to actually prevent the chain reaction of platelet activation and therefore prevent thrombosis from occurring. So both of these medications, aspirin and the P2Y12 antagonists, they can be given in order to try and prevent thrombosis from occurring if the atherosclerotic plaque, which we know is in your coronary artery, was to rupture. So they're there to try and prevent you from suffering an acute coronary syndrome if the atherosclerotic plaque does rupture. They are prophylactic medications. And if we think someone's at very high risk, then you could potentially give aspirin and a P2Y12 antagonist. But usually we prefer just to give one or the other. Okay, right, so we'll have a break there. In the next video, what we will talk about is revascularization surgery. Okay, so procedures, invasive procedures that can be done to try and reopen the blood flow to the affected area. So if drug therapy fails and we want to relieve your angina symptoms, in a surgical way, there are means to try and return normal blood flow to the affected area of the heart. But we would try medication first, and if that can't get rid of the angina, if you're still, if you're still limited hugely in your quality of life, you can't actually really do anything without getting this awful pain, then we would consider revascularization therapy. So we'll go over percutaneous coronary intervention and coronary artery bypass grafting in the next video.